name is Julien Puylaert, and this presentation deals with the role of ultrasound in the uncomplicated biliary colic. Let me start with an average patient, a young lady. She has had 2 severe episodes of colicky pain in the right upper quadrant, and there's no dark urine or white feces afterwards. And she now presents in the weekend at the ER with a 3rd colic. She's given medication and she's rapidly symptom-free. Now, the diagnosis is clearly an uncomplicated biliary colic, and the policy, at least in the Netherlands, is then that the patient is referred to her own family doctor, who is expected to request a gallbladder ultrasound and after that send her to the surgeon. 10 days later, the family doctor requests an ultrasound, and in combination with her history and this ultrasound image, it is concluded that she has symptomatic gallstone disease. Another 2 weeks later, she had a cholecystectomy and she lived happily ever after. So you could say, well, we demonstrated the gallstones, everything went fine. What is the problem? Well, it is not always this easy. Let me show you a few patients. Here, elderly man, he comes to the ER in the evening with an evident colicky pain in the right upper quadrant, normal laboratory, and with medication his symptoms rapidly disappear. So he's diagnosed as an uncomplicated biliary colic. The same policy: visit your family doctor, ask for a referral for ultrasound, and after that to the surgeon. He gets the express instruction to seek medical help in case of alarm symptoms, which means fever or more pain. So he goes home, and 4 days later he visits his family doctor with malaise and vague pain in the right upper quadrant. He has no temperature and the pain is well tolerable, certainly not comparable to the original colic, as he says. And then the family doctor decides to do a CRP, and that is 220. That's very high, and he sends the patient to the ER with suspicion of cholecystitis, which is confirmed at the hospital and is followed by a technically difficult laparoscopic cholecystectomy. Now, another patient, a man of 55 with a cardiovascular history, is referred to the coronary care unit with severe retrosternal pain, suspect for myocardial infarction, but a cardiac cause at the CCU is excluded. The pain disappears spontaneously within a few hours, and the patient is dismissed. After 6 days, he visits his family doctor with some fever and an uncomfortable feeling in the upper abdomen. The CRP is 175, and he's admitted to the emergency room, and there a long-standing cholecystitis is confirmed and a percutaneous gallbladder drainage is done, which yields 120 cc of purulent bile, and another 10 weeks later patient undergoes a technically difficult laparoscopic cholecystectomy. These 2 patients show you problem 1. Diagnostic delay, which leads to surgical delay. Late removal of the gallbladder in acute cholecystitis, you can define it as more than 48 hours after the onset of symptoms, is technically more difficult and may even lead to gallbladder drainage. And this drainage is followed by an also technical difficult elective cholecystectomy because of usually a lot of adhesions. And all this results in more complications: bleeding, abscess, subtotal cholecystectomy, the phenomenon of dropped stones with abscess formation, the worst of all, the damage to the common bile duct, and anyway, prolonged hospital stay. But there's also another problem. That's why I want to draw your attention to this patient, a lady of 57, who has multiple episodes of pain in the upper abdomen, which do not respond to proton pump inhibitors. Gastroscopy is normal, and the patient history is a little difficult due to language and cultural barriers. And then the family doctor decides to request an abdominal ultrasound, and this ultrasound shows multiple gallbladder stones. So she underwent a laparoscopic cholecystectomy, but then after the operation, the complaints of the patients are unchanged. This is the second problem: the incorrect diagnosis of symptomatic gallstone disease, which results in an unnecessary cholecystectomy. So there are in fact 2 problems in the diagnosis of symptomatic gallstone disease, which is diagnostic delay, which occurs in approximately 30%, which may result in risky cholecystectomy or even gallbladder drainage, which then a delayed cholecystectomy. And on the other hand, an incorrect diagnosis of symptomatic gallstone disease, which results in an unnecessary surgery. There is a remarkably simple solution for both problems. Do the ultrasound during the biliary colic. I can understand that radiologists who hear this might be afraid that they will have to come to the hospital in the middle of the night for every biliary colic. I can reassure them because ultrasound can also be done within 12 hours. I will explain that later. Next, it's important to repeat a CRP at 24 hours after a biliary colic, and that is to intercept an insidiously developing cholecystitis, especially in older patients. And finally, it's important to convince surgeons that if you have an ultrasound proven biliary colic, it is best to do the laparoscopic cholecystectomy as soon as possible. To understand the natural cause of the biliary colic, we have, of course, clinical follow-up and repeated laboratory. But what exactly happens in the non-operated patient can in fact only be found out by sequential diagnostic imaging, very frequent. It's remarkable that the natural course of biliary colic has never been scientifically studied. Probably because studies with very frequent sequential ultrasound are difficult to realize in daily practice. In The Hague, we have now 35 years of experience with ultrasound of the acute abdomen, and especially in the early years, I've done very often sequential ultrasound, simply out of curiosity, what exactly happened inside the patient who was not operated. I have reflected my personal impression in a table of patients presenting at the ER with a biliary colic. In 10%, the stone passes to the common bile duct. And this presentation is not about the stone which passes to the common bile duct, but the stone that remains in the gallbladder. That is not because the stone in the common bile duct is not important. In fact, a stone in the common bile duct is much more dangerous than a stone obstructing the gallbladder. You get cholangitis with sepsis, liver abscesses, you can get biliary pancreatitis, and there's a high mortality. And if you have this stone, these patients will undergo ERCP, which obviously has the risk of perforation and pancreatitis also. Interestingly, the colicky pain perceived by the patient is identical, but after 6 to 12 hours, he might notice dark urine, white feces, and cholestatic lab. And of course, then these patients are referred to the gastroenterologist for removal of the stone, sometimes after X-ray imaging. However, the stone in the common bile duct is an entirely different problem and has also been extensively studied in the literature, unlike the stone in the neck or the cystic duct. So we will only talk about these patients. So if you have 90% of patients, this stone remains here. 1% will have a free or poorly walled off perforations, quite rare. In approximately 1 in 7, it will proceed to an acute cholecystitis. And in the vast majority, you will see that the hydrops disappear. So apparently the pressure's off and either the stone is loosed, as in most cases, or we also quite often see that the stone is still in its place, but apparently the pressure's off, so the bile has been able to pass the stone to the common bile duct. Now, what do you actually see with ultrasound during a simple biliary colic? The first feature is, of course, an impacted stone in the neck or cystic duct. The second is the so-called hydrop sign. This might be more visible in this movie clip where the hydropic gallbladder bulges a little bit into the abdominal wall. If you want to make sure that the stone is really impacted, it might be necessary to let the patient stand up and see if this stone defies the laws of gravity, which means that it's impacted. Remember that we often examine the patient while lying on his back in the cubitus position, and then the stones will roll to the deepest point, which is in fact the neck or the cystic duct. This will impair the view on the neck itself and on the liver hilum. So what we often do is turn the patient on the left side, and then the stones which are free will roll to the fundus, and the obstructing stone, here marked with the green arrow in the neck, can be easily revealed. There are two small issues in the left decubitus position, and the first is that even in the left decubitus, the gallbladder may still lie quite horizontally and the stones will not move. You can turn the patient even more in the direction of the belly. A second problem is that bile is quite sticky and it may take a long time to wait until the stones have gone down. The simple solution is to let the patient stand up, bend over, and even jump on their heels. For instance, in this patient where you might suspect a stone in the neck of the gallbladder, and then you can take a quick look in the standing patient, but it's better again to put them on the left decubitus, and then you can see more clearly the stone in the cystic duct and the rest of the stones in the fundus. Even more simple, ask the patients who come for an ultrasound for suspected gallstones to wait in a standing or in a sitting erect position, and then start the examination in the left decubitus position. Acute hydrops is when the gallbladder reaches the abdominal wall. Is quite easy to visualize during expiration, where the abdominal wall muscles are more relaxed. Here is a hydropic gallbladder, and you can see that the rounded shape is preserved during slight compression, comparison with a normal gallbladder, which can easily be flattened. Sometimes you have the problem that the liver lies in between the abdominal wall and the gallbladder. Then you can use the so-called indirect hydrop sign. Here you see an acute hydropic gallbladder. Take a look at the liver and the shape of the gallbladder when there is applied some compression. You see that the liver is soft and changes in shape, but the gallbladder remains its rounded. Here a example of a non-hydropic gallbladder without compression and with compression. And then if the gallbladder is partly hidden under the costal arch, you can try left decubitus during in and expiration. In some patients, the gallbladder is localized far too high and the hydrop sign is unreliable, and this is a good indication for CT scan. The two main features of an uncomplicated biliary colic is a non-compressible gallbladder with a rounded shape in the axial plane, bulging into the abdominal wall, the so-called hydrop sign, and the second is the obstructing stone in the neck or cystic duct. The diameter of the gallbladder is unreliable. Here you have a large but non-hydropic gallbladder, and on the right you see a small but hydropic gallbladder. And also the famous sonographic Murphy sign, pain on pressure over the gallbladder with the ultrasound probe, is not always reliable. There are quite some false negative and false positive results. Now, in recent years, more and more patients with acute abdomen are immediately sent to CT scan, and this has consequences for gallbladder diagnosis. Here, an obese lady with severe abdominal pain, she was suspected for stomach perforation, and an immediate CT scan was done. And here you see some slides, and you can see that there is no free air and a normal aspect of the antrum and the duodenal bulb. The report was no free air, no ulcer, and no explanation for the pain. And after the CT scan, the pain spontaneously subsided. She was advised to come back in case of alarm symptom. This is of course not a good advice, because with the retrospectoscope, as you know, the most powerful of medical instruments, you can see that there is slight bulging of the gallbladder into the abdominal wall, comparable to what we thought just on an hydropic gallbladder on ultrasound. But this was missed at that time, and the patient came back after 3 days with some nagging pain. She apologized. She had no alarm symptoms, but she said, "I'm not feeling well. I have no fever." And then the CRP was high, and she had on ultrasound an acute cholecystitis. Eventually, a technically very difficult but eventually successful laparoscopic cholecystectomy was performed. So what we learn from this case, if CT is not conclusive after a serious pain episode, do an ultrasound, even if the pain is completely gone at that time, to know what has caused her pain. Second, an acute cholecystitis may develop insidiously. The pain is much less than the original colic, and fever may not be there. So alarm symptoms, especially in the elderly, are unreliable, and CRP repeating is the best policy. And of course, as soon as the diagnosis of symptomatic gallstone disease is made, you can try to convince the surgeon to do a cholecystectomy as soon as possible. To prevent unnecessary diagnostic delay and unnecessary cholecystectomies, do the ultrasound during the biliary colic. You shouldn't be afraid that all these patients are sent to you in the middle of the night, because it can also be done within 12 hours. To explain this, I want to demonstrate a patient. Elderly lady, she occurs in the middle of the night with severe pain, collapse, vomiting. She has a little leukocytosis. In the morning, the pain is over. And ultrasound is done at 9 o'clock. And what we see is a small gallbladder which has a markedly thickened wall with edema, and there's of course no pain anymore. The diagnosis and policy was, well, apparently some colic, The policy was to wait and see. We asked the patient, will you please come back after 2 days, simply because we wanted to see what happened to the gallbladder. And then we saw, after 2 days, a completely normal, thin-walled gallbladder. And the patient is still symptom-free. There's no doubt that this must be a biliary colic. But what is the reason, the cause of the transient wall thickening? To understand this, you must compare the situation after bowel and brain ischemia. What happens there? And this is the same. What happened here is a reperfusion edema. This is a gallbladder during a colic. On the right side, you see the hydropic gallbladder moving to and fro with inner exploration. During the colic, the wall of the gallbladder keeps on secreting mucus until there is very high pressure in the lumen. And this will result in such a high pressure that it exceeds the pressure in the vessels of the gallbladder wall, which of course will result in temporary ischemia of the wall due to this high pressure. If the stone gets loose spontaneously or by medication, the pressure is suddenly off and you will get reperfusion edema, which is then a so-called silent witness of the biliary colic. Another patient, a young lady who came to the ER with a biliary colic. We did an immediate ultrasound and we saw a stone in the neck of the gallbladder. When she stood up and even was bending over and jumping on the heels, the stone didn't move, and there was clearly within an exploration hydrops of this. So we said, well, the best thing is to get your gallbladder removed as soon as possible. And she said, well, that's a little problem. I have a wedding party tomorrow, very important to me, and I want to be there. Is there a way that I can avoid surgery? So we did some thinking and we gave her Buscopan and the advice to run around a little. And she said, with pleasure, because she has in fact an urge to move with her biliary colic. So she went down for some running, and after 45 minutes we repeated the ultrasound. And here you see that the stone is loose, and on actual sections you can clearly see that there is reperfusion edema of the gallbladder wall as a silent witness of her colic. And that disappeared rapidly within 6 to 12 hours. Here another case. This is ultrasound done during a colic. There's a hydropic gallbladder with a stone impacted in the neck. And after medication, she was symptom free. And we asked her to come back the next day. And we thought that the stone was still in place, but it was apparently a collapsed gallbladder with some sludge and reperfusion edema of the neck. So apparently the bile was able to pass the stone, probably due to this spasmolytic medication. Another patient with a nocturnal colic admitted to the emergency room. In the morning, the patient was sent for ultrasound. He was at that time completely symptom-free, and here you see a contracted gallbladder filled with stones. The patient had not eaten over the last 12 hours. We asked him again to come back after 6 days. He was still completely symptom-free. And now we see a completely deployed gallbladder with free moving stones in this fasting patient. So also in this case, the contracted gallbladder was a sort of silent witness of the previous colic. Here are ultrasound images of 8 different patients. All underwent ultrasound within 2 to 12 hours after a serious biliary colic. And very important, all 8 patients were, at the time this ultrasound was done, completely symptom-free. And you see in different patients a lot of sludge, also in several cases contraction and reperfusion edema in several patients. And also in patient G and K that the obstructing stone is still in place, but apparently not obstructing anymore at this point. So doing the ultrasound within 12 hours is most important, is to see if the hydrops is still present, and if not, you have to recognize the silent witnesses: reperfusion edema, hyperemia, sludge, and contraction, which you can consider as a kind of after labor. And then it's very convenient to repeat the ultrasound to prove that it actually normalizes. Interesting is that in some patients the stone remains impacted, but the bile has apparently been able to pass the stone. You would say that these patients have more chance for cholecystitis, but that subject has never been studied. Well, the best policy is, of course, do the ultrasound during the colic. You catch the gallstones red-handed, and the diagnosis is certain, and there's no delay of operation. The surgeons themselves call it the golden hour of surgery. Cooperation of the surgeons is crucial because they have to create time slots in the OR to allow surgery within 24 hours. And second best is, of course, ultrasound within 12 hours after the colic. Is hydrops or impacted stones often still present? And if not, search for silent witnesses and repeat the laboratory, CRP, glucose, and of course also search for cholestasis. And then do a follow-up ultrasound to confirm normalization. Thank you for your attention.